Hello, everyone, and welcome. Today, we're diving into the world of drugs used to combat bacterial infections. This is a crucial topic for all healthcare professionals, especially nurses. In this session, we'll cover key learning objectives, including differentiating between pathogenicity and virulence. We'll also explore bacterial classification, resistance development, and the role of culture and sensitivity testing. Finally, we'll discuss how host factors influence treatment success. Microbes are everywhere, and while many are harmless, some can cause illness, especially in compromised environments or when present in large numbers. Understanding this balance is key to understanding infections. Not all microbes are enemies. Some live peacefully in our gut or on our skin, but when they show up in the wrong place or grow in large numbers, they can turn hostile. Pathogenicity refers to an organism's ability to cause infection, while virulence describes the severity of the disease it can produce. Highly virulent microbes can cause disease even in small numbers. Pathogenicity, how ability to cause disease. Virulence, how bad the disease gets. A highly virulent microbe doesn't need many troops to take down your defenses. If I said Ebola is highly virulent, does that mean it's common or just deadly? Type your answer. Now let's delve into how we classify bacteria. Gram-positive bacteria have a thick cell wall that retains the stain, resulting in a purple color under the microscope. This structural difference is crucial for antibiotic selection. Gram-negative bacteria, on the other hand, have a thinner cell wall and an outer membrane, causing them to stain red or pink. This difference in cell wall structure affects antibiotic penetration. Bacteria come in various shapes, including round, cocci, rod-shaped, bacilli, and spiral. These shapes can help in initial identification. Bacteria are also classified by their need for oxygen. Aerobic bacteria require oxygen to survive, while anaerobic bacteria do not. Let's define some key terms we'll be using throughout this presentation. Antimicrobials encompass a broad range of agents, including anti-infectives, antiseptics, and biocides. Anti-infectives further break down into antivirals, antibacterials, and antifungals. Antibiotics are a subset of antibacterials. Think of antimicrobials as a big umbrella. Underneath it are antivirals for viruses, antifungals for fungal infections, and antibacterials for bacteria. Antibiotics are a specialized group within antibacterials that we use most often in clinical settings. An anti-infective is any drug effective against pathogens, while an antibiotic specifically targets bacteria, either inhibiting their growth or killing them directly. Anti-infectives can kill or stop the growth of any kind of pathogen, bacteria, fungi, viruses, or parasites. Antibiotics are only effective against bacteria. They either stop the bacteria from multiplying, bacteriostatic, or kill them outright, bactericidal. Now, let's focus on antibiotic classification. Antibiotics are grouped by their chemical structure. This helps us predict how they work, their side effects, and which bugs they're effective against. Common classes include penicillins, cephalosporins, tetracyclines, macrolides, aminoglycosides, and fluoroquinolones. Antibiotics are classified based on their chemical structure. Understanding these structures helps us understand their mechanisms of action and potential side effects. For example, beta-lactam antibiotics all share a beta-lactam ring and act by inhibiting bacterial cell wall synthesis. Knowing this helps us understand that allergic reactions to one beta-lactam may affect other drugs in the same class, like penicillins and cephalosporins. Antibiotics work by targeting different processes within the bacterial cell, such as RNA synthesis, protein synthesis, DNA synthesis, or cell wall synthesis. Each class of antibiotics has a specific mechanism of action. Bacteriostatic agents inhibit bacterial growth, allowing the host's immune system to eliminate the infection. Bactericidal agents directly kill bacteria. Bacteriostatic box, pause, and wait, like tetracycline or sulfonamides. This distinction helps us decide which to use in different patients. For example, in immunocompromised patients, bactericidal agents are often preferred because their immune system can't finish the job. Broad spectrum antibiotics are effective against a wide range of bacteria, both gram positive and gram negative. Narrow spectrum antibiotics target specific types of bacteria. Broad spectrum drugs like amoxicillin or ciprofloxacin are helpful when you're not sure what bacteria is causing the infection, but they also disrupt the good bacteria, increasing the risk of superinfections. Narrow spectrum antibiotics like penicillin G are more targeted and often preferred when the culprit is known, which is more likely to cause a yeast infection. Broad spectrum or narrow spectrum antibiotics. Antimicrobial resistance is a growing global threat. Every time an antibiotic is used improperly, wrong dose, wrong duration, or wrong infection, bacteria evolve. Superbugs like MRSA and VRE are the result. This makes once effective drugs useless and infections harder to treat. It's important to remember that antibiotics don't create mutations. Bacteria become resistant, and this resistance can be transmitted. Overuse and improper use of antibiotics contribute to resistance. Antibiotics don't cause the mutation, they just help resistant strains survive. These strains then spread, especially in hospitals or poorly sanitized settings. It's like natural selection in action, but for microbes. Antibiotic resistance develops when bacteria mutate or acquire resistance genes, allowing them to survive antibiotic exposure. These resistant bacteria then multiply, making the antibiotic ineffective. Resistance can spread in two ways. Mutation, random genetic changes that help survival horizontal gene transfer. Bacteria share resistance genes like swapping cheat codes. That's why one person's misuse can affect an entire community. As nurses, what can we do to prevent antimicrobial resistance? We're not just administering meds, we're gatekeepers of antibiotic safety. Nurses have a major role in preventing infections through hand hygiene, ensuring vaccines are up to date, encouraging cultures before antibiotics, educating patients to complete prescriptions, watching for signs of resistance and adverse effects. Nurses play a crucial role in preventing resistance by preventing infections, promoting immunizations, ensuring appropriate antibiotic prescribing, advising patients on completing their therapy, and implementing infection control measures. Let's reinforce these. Hand washing, first line of defense, vaccination, less chance of infection, less need for antibiotics, patient education, prevents misuse and premature discontinuation, antibiotic timeouts, reevaluate if the drug is still needed after 48-72 hours. Superinfections occur when antibiotics kill beneficial bacteria, allowing opportunistic pathogens to overgrow. Be vigilant for signs and symptoms like fever, diarrhea, or abnormal discharge. Superinfections include things like C. diff, profuse diarrhea, foul odor yeast infections, oral thrush, or vaginal discharge secondary pneumonia after viral illness. Laboratory analysis is essential for identifying the causative organism and determining its susceptibility to antibiotics. You can't treat what you can't see. Cultures help pinpoint the bug, and sensitivity tests tell you what will kill it. Collect samples before starting antibiotics whenever possible to avoid false negatives. Scenario. Example. A patient spikes a fever and the provider orders blood cultures. Do you give the antibiotic first or draw the blood first? Always draw first. Microorganism identification involves techniques like gram staining to differentiate between gram-positive and gram-negative bacteria and determine their shape. Gram stain is quick and inexpensive, your first clue at the crime scene. The color and shape help lab techs narrow it down. Cocci in clusters, likely staph. Rod-shaped pink bacteria, maybe E. coli. Culture and sensitivity testing helps determine which antibiotics will be most effective against a specific infection. Nursing staff and pharmacy are valuable resources in this process. The culture identifies the pathogen. The sensitivity test shows which antibiotics stop its growth. The lab usually reports S, sensitive, I, intermediate, R, resistant. Work with the provider and pharmacist to adjust meds based on these results. Real-world tip. Always follow up on the CNS report within 48 hours. Don't assume the current antibiotic is still appropriate. A white blood cell count with differential measures the proportions of each type of white blood cell in the blood, providing insights into the body's immune response. WBCs give us a window into the immune system. Neutrophils rise with bacterial infection. Lymphocytes rise with viruses. Eosinophils rise with allergies or parasites. White blood cells are divided into granulocytes, neutrophils, eosinophils, basophils, and agranulocytes, lymphocytes, monocytes, each with specific roles in fighting infection and inflammation. Granulocytes have visible granules and act fast. Neutrophils, bacterial killers, eosinophils, allergic reactions and parasites. Basophils release histamine. Agranulocytes are slower but essential for long-term defense. Lymphocytes, B and T cells, monocytes, become macrophages. Patient-specific factors such as local tissue conditions, allergy history, age, pregnancy status, and genetics can all affect the success of anti-infective therapy. It's not one size fits all. Always consider age. Infants and elderly have altered metabolism allergies. Penicillin allergies are common and serious. Pregnancy. Avoid drugs like tetracyclines and sulfas. Genetics. Some patients metabolize drugs differently or are at risk for toxicity. A left shift in the WBC count indicates acute inflammation, with immature neutrophils suggesting a more intense inflammatory response. When the body is overwhelmed, the bone marrow sends out baby neutrophils called bands. If you see a rise in bands, it means the body is fighting hard, often due to bacterial infection or sepsis. Let's move on to specific antibiotic classes, starting with penicillins. Penicillins were the first true antibiotics discovered, and they're still widely used today. They work by destroying the bacterial cell wall, which weakens the bacteria and causes it to burst. Fun fact, Alexander Fleming discovered penicillin by accident when he noticed mold-killing bacteria on a petri dish. Penicillin G is the prototype penicillin. Common adverse effects include nausea, vomiting, and diarrhea. Anaphylaxis is a serious potential adverse effect. Penicillin G is often given IV or IM. It's great for strep, meningitis, and even syphilis. But the biggest concern is allergy. Some reactions can be life-threatening. Always ask about allergies before giving any cillin drug. Nursing alert. Monitor for rash, hives, wheezing, or swelling after the first dose, especially if the patient has a known allergy. Next, we'll discuss cephalosporins. Cephalosporins are cousins of penicillin, with a similar mechanism. They also break down the bacterial cell wall. They're classified into generations, with each new generation having broader spectrum and better resistance to beta-lactamase enzymes. Cefazolin is a prototype cephalosporin. Be aware of potential cross-sensitivity allergies with penicillin. It's commonly used for surgical prophylaxis. Cefazolin is often used before surgery to prevent infection. It's first generation, gram-positive focused. But if your patient is allergic to penicillin, use caution. Some cross-reactions can occur, especially with earlier generations. Clinical tip: always check for penicillin allergy before giving cefazolin. If it's a mild rash, maybe okay, but if it was anaphylaxis, stop. Here's a mnemonic to help you remember the different generations of cephalosporins. Each generation has its own spectrum of activity. Let's break it down. First gen, e.g., cefazolin, mostly gram-positive and gen, e.g., cefuroxime. Add some gram-negative third gen, e.g., ceftriaxone. More gram-negative can cross BBB fourth gen, e.g., cefepime. Broadest coverage fifth gen, e.g., ceftaroline, covers MRSA. Now let's talk about tetracyclines. Tetracyclines block protein synthesis in bacteria, stopping them from growing. They are used for acne, Lyme disease, chlamydia, and respiratory infections. Nursing alert: tetracyclines bind to calcium, so no milk, antacids, or iron within 1-2 hours of dosing. Tetracycline can cause permanent teeth discoloration in children. It's contraindicated in pregnant women and children under 8. Administer on an empty stomach. Tetracyclines get deposited in growing teeth and bones, so it's a no-go for little kids and pregnant patients. Tetracycline can cause teeth discoloration. Here's a visual reminder. Long-term use during tooth development can lead to yellow, gray, or brown discoloration. That's why age restrictions are so important. Let's move on to macrolides. Macrolides are another class that inhibit protein synthesis. They are great alternatives for patients allergic to penicillin. They treat respiratory infections, skin infections, STIs, and more. Erythromycin is the prototype macrolide. Common adverse effects include nausea, vomiting, and diarrhea. Serious adverse effects include ototoxicity and hepatotoxicity. Erythromycin is effective, but can be tough on the stomach. Give with food to reduce GI upset. In high doses or long-term use, it can affect hearing or liver enzymes. Nursing tip: monitor for tinnitus, ALT, AST elevation, or signs of liver damage like jaundice. Now, let's discuss aminoglycosides. Aminoglycosides are powerful bactericidal antibiotics that disrupt bacterial protein synthesis. They're often reserved for serious infections caused by gram-negative bacteria, such as sepsis, respiratory infections, or infections resistant to other antibiotics. Nursing tip: these drugs are strong but risky. Watch your labs and hearing closely. Gentamicin is a prototype aminoglycoside. Monitor peak and trough levels to prevent nephrotoxicity and ototoxicity. Gentamicin is IV or IM only, never oral, and it doesn't cross the GI barrier. Trough levels tell you the lowest concentration before the next dose. Too high, and it builds up. Peak levels help confirm you're hitting the therapeutic range without going toxic. Monitoring. Tip: watch for tinnitus, ringing in ears, and check kidney labs like creatinine and bune. Next, we'll cover fluoroquinolones. Fluoroquinolones inhibit bacterial DNA synthesis. They block enzymes like DNA gyrase. They're broad spectrum and treat UTIs, respiratory infections, GI infections, and even anthrax. Ciprofloxacin is a prototype fluoroquinolone. Be aware of the risk of tendon rupture. Administer at least 4 hours before antacids and iron products. Ciprofloxacin is commonly used for UTIs and traveler's diarrhea, but it's not without risks. The black box warning for tendonitis and tendon rupture means it's usually avoided in athletes, children, and older adults. Do not give with calcium, magnesium, or iron. These bind the drug and reduce absorption. Patient teaching tip: report any heel or ankle pain right away. It could mean tendon damage. Let's move on to sulfonamides. Sulfonamides are among the oldest antibiotics. They're bacteriostatic, working by inhibiting folic acid synthesis, which bacteria need to multiply. They are commonly used to treat UTIs, MRSA, and some respiratory infections. Clinical note: these drugs can cause serious skin reactions and bone marrow suppression, so monitor your patient closely. Trimethoprim sulfamethoxazole sulfa can cause photosensitivity and crystalluria. Monitor for bone marrow suppression. Avoid in the last trimester of pregnancy. This combo drug is commonly called TMP-SMX or Bactrim. Photosensitivity means sunburn risk, so sunscreen is a must. Crystalluria is crystal formation in urine. Keep patients hydrated. Avoid in pregnancy. It can harm the baby, especially near term. Red flag reminder: if your patient develops a rash, stop the drug and alert the provider. It may be the beginning of Stevens-Johnson syndrome. Now let's discuss isoniazid. Isoniazid, INH, is the first-line drug for tuberculosis. It works by inhibiting mycolic acid synthesis in the bacterial cell wall of Mycobacterium tuberculosis. It's given as part of a combination regimen to prevent resistance. Nursing tip: teach your patients to report tingling in fingers and toes. It could be peripheral neuropathy. Isoniazid is a prototype drug for tuberculosis. Common adverse effects include numbness in the hands and feet. Monitor for hepatotoxicity. INH can cause liver damage, so monitor ALT and AST regularly. Teach patients to avoid alcohol. Also, monitor for symptoms like fatigue, dark urine, or jaundice. Real-world tip: if your patient is on multiple TB meds, check for drug interactions. Rifampin and INH can both affect the liver. Let's move on to carbapenems. Carbapenems are broad-spectrum beta-lactam antibiotics. They are reserved for serious infections resistant to other drugs. They destroy bacterial cell walls like penicillins, but are more powerful and resistant to beta-lactamase enzymes. Carbapenems are broad-spectrum antibiotics resistant to beta-lactamase. They are administered intravenously only. A serious adverse effect is a lowered seizure threshold. Because of their potency, carbapenems are IV only. A key risk is neurotoxicity, especially in patients with renal impairment or those on high doses. Watch for signs of confusion, twitching, or seizures. Nursing tip: check renal function and adjust dosing if needed. Always review the medication profile for seizure history. Now, let's discuss vancomycin. Vancomycin is the go-to drug for resistant gram-positive infections, especially MRSA, methicillin-resistant Staphylococcus aureus. It inhibits bacterial cell wall synthesis, but in a slightly different way than penicillin. Important note: vancomycin is not absorbed orally unless used to treat C. difficile inside the gut. For systemic infections, it must be given IV. Vancomycin is the drug of choice for MRSA infections. Monitor peak and trough levels. Be aware of the risk of Redman syndrome with rapid IV administration. Monitoring peak and trough levels is critical to avoid nephrotoxicity, kidneys, and ototoxicity, ears. Trough, collected just before the next dose, shows the lowest level peak. Collected shortly after infusion shows the highest level. And don't forget about red man syndrome, which occurs if vancomycin is infused too quickly. Pro tip: always infuse vancomycin slowly, over at least 60 minutes. Use a pump to avoid errors. Redman syndrome. This is not a true allergic reaction. It's a histamine release that causes flushing, rash, hypotension, and sometimes chest pain or back pain. Redman syndrome typically happens when the IV is infused too fast. What to do? Stop the infusion, monitor vitals, and notify the provider. Antihistamines like diphenhydramine may be given, and the infusion can be restarted at a slower rate. Remember, nurses are educators in ensuring therapeutic effects and minimizing adverse effects, and don't hesitate to use your resources, especially the pharmacy. As nurses, we are often the last checkpoint before the medication reaches the patient. Our role includes monitoring labs like WBC, kidney, liver function, teaching patients to take meds properly, reporting side effects and changes, collaborating with pharmacy and providers. Now, let's test your knowledge with some review questions. Let's put everything you've learned into action. As we go through these NCLEX style questions, pause and think before answering. Grab a notebook if you want to test yourself more actively. Drop your answer choices in the comments. Don't worry if you get it wrong. This is how we learn. Which of the following best describes a superinfection? Correct answer: D. The overgrowth of normal body flora or of opportunistic organisms. Superinfections happen when good bacteria are killed by antibiotics, allowing bad bacteria or fungi to overgrow. Examples include C. diff, thrush, or yeast infections. What should a nurse include in at-home instructions for a patient being discharged with a prescription for penicillin? Correct answer: B. The entire prescription must be finished. Stopping antibiotics early, even when you feel better, can lead to relapse or resistance. Always finish the full course, unless told otherwise by a provider. Tip for teaching: explain the why. Patients are more likely to comply when they understand the reason. What information should a nurse include when providing information about tetracycline to a patient? Correct answer: D. It is contraindicated in children younger than 8 years. Tetracyclines can cause permanent teeth discoloration and affect bone growth in kids. They are also avoided in pregnant women. Pro tip: also teach to avoid dairy, iron, and antacids within a few hours of dosing. These reduce absorption. What important information should be included in patient education regarding ciprofloxacin? Correct answer: C. Any heel or lower leg pain should be reported immediately. Ciprofloxacin and other fluoroquinolones carry a black box warning for tendon rupture. This can happen during treatment or even months later. Safety tip: older adults, athletes, and steroid users are at higher risk.